Our next presentation, Magnet4Europe, improving mental health and well-being in the healthcare workplace. Presented by Professor Jonathan Drennan from University College Cork, Ireland. So let's see the presentation of Magnet4Europe. Okay, so Professor Jonathan Drennan, he's the lead of the Irish branch of the Magnet4Europe project. He currently holds the chair of Nursing and Health Services Research at University College Cork, and he previously held the chair of Healthcare Research at the University of Southampton. He has experience in clinical research, research also into higher education, evaluation of health service initiatives, older persons research, sexual health, women's health, psychometrics, and research methods, and also health workforce research. So I give the floor to Professor Jonathan.
Good morning, everybody, and thank you for the opportunity to present at the webinar this morning. I'm presenting on behalf of the Magnet4Europe research team, which is looking at improving mental health and well-being in the health workplace. Just to introduce the team, it's led by Professor Walter Sermus from KU Leuven, and with our US colleague, Professor Linda Aiken from the University of Pennsylvania. Other members of the consortium include the Technological University in Berlin, the Karolinska Institute in Sweden, and then three institutions in the UK, the University of Southampton, London School of Hygiene, Tropical Medicine, and King's College London, and ourselves at University College Cork. We also have MEPLIS, which is our partner in relation to developing the platforms for sharing and software and data collection, and a Magnet hospital in Europe, the University Hospital in Antwerp. As you can see, it spans across Europe, from Ireland across to Sweden. We also have partners in Norway, which are part of the Swedish consortium. And just to give a very brief overview of what the project is setting out to achieve. It's a 3-year project, and the objective is to evaluate the effect of an organizational redesign guided by what is known as the Magnet blueprint, and I'll come to that in a moment. And it's looking at the impact of this organizational redesign on nurses and physicians' mental health and well-being within the acute hospital setting across Europe. The design is a wait list cluster randomized controlled trial with a nested mixed methods evaluation. The wait list is used so that everybody at some stage will achieve the intervention and implement the process. As I said, it's acute hospitals across Europe, 67 large hospitals across Europe, and then the countries, as I mentioned, are there. So looking at the background and rationale for the study, the prevalence of job-related burnout is greater in the healthcare setting than other settings, and this is very much related to the nature of the work. A large European study identified that burnout rates range, depending on the country surveyed and looked at, but can range anywhere from 10 to 78% amongst nurses and 25 to 60% amongst physicians. There's been a lot of work done in this area on the nursing workforce, but not so much on the physician workforce. What we do know and what we're seeing from studies that have been published recently and from the work that we're doing on the ground, that these ranges of burnout and the impact on healthcare staff of COVID-19 is leading to increased pressures, increased challenges, and increased levels of burnout due to the COVID-19 pandemic, and the need to reorganize services, the demand on services from caring for critically ill patients, has led to this experience increasing within the health workforce. So in some respects, even though there are challenges with implementing the intervention, it's coming at a time which staff need. We know that the impact of burnout on the healthcare staff can be quite detrimental, both to the individual at individual level and at organizational level. So the primary effects of burnout and the stresses of healthcare work can lead to anxiety, depression, substance abuse, and in some cases been recorded higher rates of suicide. The other areas in relation to it are areas in relation to lost productivity due to absenteeism, turnover rates, both leaving a hospital and leaving the profession, are issues that can occur due to the nature of healthcare work. And it can also have an impact on patient care, an increase in adverse events for patients, an increase in medical areas, reduced quality of care delivered, and reduced patient safety. And these issues can undermine what are already scarce resources. We know the World Health Organization recently produced a report on the nursing workforce, and currently worldwide there's a shortage of about 6 million nurses. So in relation to identifying strategies and interventions that can enhance the well-being of the health workforce and enhance recruitment and retention is what this project is looking at. When we look at the strategies and we look at the implementations that are available, a lot of the stresses and strains come from rooted within the work environment. The shift work, day shift, night shifts, long hours, 12-hour shifts at a time, and so on. The workload, the demands. We can see across Europe that occupancy rates of hospitals is increasing. Some hospitals are reporting over 95 to 100% occupancy rates, large patient turnover, and this has huge demand on the healthcare workforce. Another issue is the workforce itself in relation to the numbers that are available to provide care and the skills of the workforce to provide that care. So the team looked at two strategies for designing health work. There's the primary, which is all looking at the organizational stress intervention strategies, which is reducing the stress and reducing demands and increasing job resources, or the secondary, which is the individual stress intervention strategies. So the primary organizational one we're looking at is known as a magnet intervention, this is the 5 aspects within it. So the magnet hospital concept originated in the early 1980s, and this was identified in the US, where there were hospitals within the US that had high levels of retention of staff, better working environments, and they had lower nurse burnout, lower intention to leave, higher levels of job satisfaction, improved patient safety and clinical outcomes. These hospitals were also identified as having a shorter length of patient stay, reduced readmission, and they had also avoided costly staff turnover as an aspect of it. So magnet hospitals are predominantly identified within, are found within the US. There are just 2 magnet hospitals within Europe, at the University of Antwerp and Nottingham NHS Trust in the UK, and there are other magnet hospitals within the Middle East as well. But the magnet principles have not really transferred into Europe to the extent which they were thought of transferred. And this is, even though there is a large body of evidence there from the US that shows that the organizational redesign and the implementation of these magnet principles has an effect on the recruitment and retention of healthcare staff. It predominantly set out as working, and it's the American Nursing Credentialing Center in the US that implements this system and monitors the system, but it predominantly was set up for the nursing workforce, but we are also including the physician workforce in this, as it's an organizational redesign in relation to it. So there are, as I mentioned, there are 5 main principles in relation to the intervention, which are part of the Magnet Hospital intervention. The first is transformational leadership. And this is looking at developing leadership within hospitals that looks at problems in the broadest sense and looks at a more strategic approach to developing the workforce within their particular hospitals. It looks at the quality of leadership and hospital leaders and looks at the development of vision, influence, clinical knowledge in nursing practice. It's looking at how leadership can be used to transform the workforce within the health system that they're working. The second principle then is structural empowerment. And this is allowing staff to be innovative, allowing staff to have a voice within the organization, and looks at the reorganization of practices in relation to it. Hospitals can have a very hierarchical structure, and this can impact on decision making and can impact on the collaborations that are going to occur. And we know in relation to the demands in acute hospitals, there is a strong need for team working and there's a strong need for decision making, but to allow staff who are closest to the patient, those that are provide bedside care, to have a voice within the organization can be very, very effective. So this is where the healthcare staff who provide the majority of care, their voice can be heard and they can have a say in relation to the development of it. The third area is looking at exemplary professional practice. And this is that the Magnet Hospital program encourages institutes to use best practice and evidence and to implement change that will have an impact on health outcomes. So it's looking at the development and the use of knowledge, the development of evidence-based, the development of research, and allowing nurses and physicians who provide the majority of care at the bedside to initiate that change and lead that change. And also looking at empirical quality results, measuring the outcomes that occur as a consequence of the implementation of the Magnet principles, looking at the patient outcomes, looking at the impact that nursing care and physician care is having on patients, and using data to make those changes in relation to it. So to implement the Magnet Hospital evaluation, there are a number of things that have been done, which I'll come to in a moment. But the hospitals are provided by a number of resources, including the expertise of Magnet hospitals in the US through a twinning partner, the ability to collaborate with hospitals across Europe through learning collaboratives, which I'll speak about in a moment, and also the ability to access manuals, data, and resources in relation to it. So based on the Magnet principles, the overall objective is to improve the mental health and well-being of physicians and nurses in European hospitals. And through this, we're doing is implementing the evidence-based co-created intervention to achieve better clinical working environments. And this co-creation is really central to it, is that hospitals in Europe, the 67 hospitals across Europe are twinned with 67 Magnet hospitals in the US for this collaboration and co-design approach. And this is done through regular meetings between the hospitals, weekly, two-weekly, basis. And we're also evaluating the effectiveness of the intervention on mental health well-being of health professionals, and I'll come to some of the measures that we're using there in a moment, and to look at the impact of the intervention on patient outcomes, and also as well looking at whether it impacts on areas such as staff turnover, absenteeism rates, and so on. There's also an economic evaluation, looking at the costs in relation to implementing it, and looking at the costs of the extent to which patient outcomes improve. One of the things we're also looking at is, as we said earlier on, even though there's a body of evidence that has showed the success of the Magnet principles within the US, it hasn't transferred as successfully into the European setting. So we'll be looking at the barriers and enablers of this, and as the process rolls out within the European hospitals, what is enabling this to be implemented and the barriers to it as well. And then looking at the recommendations that come from the studies that we're undertaking within the hospitals, and looking at the impact that is having, and then looking at whether this can be implemented at policy level, looking at whether it's transferable into other healthcare settings. We know Europe is undertaking a great shift to providing more and more care within community settings, even though our acute sector is under huge strain at the moment. But looking at whether the Magnet principles can be transferable to other settings and other healthcare institutions. So what we're looking at is really, there are three key principles. Innovation through collaboration. Collaboration is central to it. Collaboration between universities, but more importantly, collaboration between the hospitals. So the hospitals come together at a national level, so each country would have its own national meetings. They come together at a European level through the collaborations, and they come together at an international level through the twinning aspect of it. The second key principle is the internationality. So we've got countries across Europe, we've got our US partners involved within it, and multidisciplinarity. This involves really, we're looking at physicians and as well as looking at the nursing workforce. And then as the multidisciplinarity on the research team, we have nurses, we have physicians, we have health economists, statisticians, psychologists, occupational psychologists, and so on. A big aspect then, the third key principle, is the communication and dissemination of the work. And this is done through websites, through newsletters, through the monthly learning collaboratives, where we have approximately 250 to 260 participants every month in relation to it. So there's a big process of the communication. And by bringing the hospitals together who are involved in the Magnet principle, they communicate and disseminate best practice with each other. There's a lot of sharing that goes on in relation to it. So they're the three key principles that we're looking at. If we're looking at the intervention and the attributed benefits, so we know that the focus is on the large body of knowledge that comes from the US that has looked at both cross-sectional and longitudinal studies that looked at the impact of Magnet hospitals on staff, patient and organizational outcomes, and the positive aspect of that. Because it's an organizational redesign, we're also bringing in physicians, and we can see that collaboration amongst healthcare professionals is increasing all the time due to complexity of patient need. What we're looking to do is provide better work environments for staff, and we know that the organizational environment has a big impact on healthcare staff, both in terms of recruitment, retention, and their health and well-being, and then the improved job-related outcomes, the impact on burnout, reduction in turnover, and leading to higher job satisfaction. So the 5 elements there in relation to it are the Magnet Blueprint and Gap Analysis tool. Each hospital is facilitated through their twin to look at where they are in relation to the Magnet principles. They identify the gaps that they have and then how to close those gaps through that. And they work very closely with their Magnet twin on doing that. The other thing, it's a co-design. There's a lot of learning from Europe and the US in how health systems, yes, the health systems even across Europe are different and very different from the health systems within the US, and how those health systems are funded and so on. But what we found is that one-to-one twinning, so each hospital has a twin, each hospital in Europe is twinned with a hospital in the US. there's a lot of co-learning going on between the hospitals, particularly during the COVID-19 pandemic, how hospitals managed and coped with the surge of patients who were very ill. The learning collaboratives bring together expertise. They're held monthly, they're hosted online. Again, the COVID-19 pandemic allowed us in some respects to move we had to move a lot of the resources online. It was originally planned that there'd be more face-to-face meetings, that US partners would travel to Europe and European partners would travel to the US, but of course that stopped. So the learning collaboratives were seen as being really important, and they've continued on a monthly basis. And they give the hospitals an opportunity to discuss best practices, but also to learn from experts within Magnet, both from the American Nurses Prudential Center and hospitals who have long-standing Magnet status in the US. And because of the number of hospitals we're looking at, there are approximately 67 hospitals, as I said, across Europe. It's building up a critical mass. And the networks that have been created both within hospitals across Europe and across the US has been really strong. There's developing a really good network between the hospitals. And then actionable feedback reports. We're getting feedback and we're able to action on those in relation to it. The other aspects that we're looking at in relation to it is, as we said, the hospitals that are included, 67 acute care hospitals. We chose acute hospitals, those large general hospitals that provide acute care. In fact, that they're the largest employer of large employers of healthcare staff across Europe. And none of the hospitals had Magnet designation prior to it. Hospitals have 150 or more beds, and I said, and it's acute care for adults. So children's hospitals, maternity hospitals, specialist hospitals are not included at this stage. We randomized the hospital then to the immediate intervention or a waitlist control group, but the waitlist control group are now part of the intervention. That stage has also started. And as I mentioned, each hospital is twinned with a US Magnet designated hospital. Hospitals are matched in terms of speciality and size and so on. And then health professions practice as a physician or registered nurse in the hospital, and then those who have direct patient contact and work in various healthcare settings, including intensive care emergency departments, as well as medical surgical wards. So these are the participating hospitals across Europe, 14 hospitals in Belgium, 7 in the immediate group, 7 in the wait group, and so on. Germany, 20 hospitals. Ireland has 15, UK 14, Sweden 3, and Norway 1. And we can see that the US Magnet hospitals go from the East Coast, right across from New York and New Jersey, right across to California, and so on. This has challenges in relation to time differences. You can imagine sometimes the US are joining meetings at 3 or 4 o'clock in the morning in relation to those on the West Coast, but those issues have largely been overcome in relation to the timing and the collaborations that go on. And there's a lot of sharing of documentation, a lot of sharing of best practice between the European and the US hospitals. And this is an example of just some of the US hospitals. You can see the Cleveland Clinic, Stanford Healthcare, San Diego Health, Hackensack, Emory Health, Northwell Health Systems, which are a large provider in New York, and Mount Sinai Hospital, Long Island Jewish, and so on. So there's a large number of hospitals across the US that are involved. And these are hospitals, the vast majority of them have long-standing Magnet designation. In relation to the evaluation of the impact, we are collecting data from a number of sources. In relation to the evaluation there are ongoing clinician surveys, and baseline data has been collected both from the both groups of hospitals, the intervention and the wait group hospitals. And we're looking at mental health and job outcomes in relation to the measurement of burnout, job satisfaction, engagement, intention to leave. We're also looking at the work environment, the practice environment which staff work in, which looks at the relationships between nurses and physicians, the level of staffing that they have and the workload, staff perceptions of quality of care, staff perceptions of patient safety. And again, all these were in relation to online. We're also looking at patient outcomes through secondary data, through hospital administrative systems, routinely collected data from hospitals on patient mortality, length of stay, readmission rates, as well as the patient experience. A number of hospitals undertake large-scale patient experience surveys. And then from the hospital administrative data systems, turnover rates, vacancies, and the proportion of hospitals which use agency staff. Can you still hear me? I lost you.
Yes, we can hear you.
Hello, sorry, might have lost you for a second.
Can you hear us?
Yes, can you hear me now?
Yes, I can hear you.
I think I lost you for a second. So patient care, health system care, clinician survey are the main outcomes, as well as qualitative work and looking at the processes in which the system then becomes normalized within it. It's a big undertaking for staff to implement the intervention, but working through the processes, it's working really well. We're going to take a look at a cost effectiveness of the intervention, and the model is there. I won't go through it in detail, but it's looking at the quantification in relation to the impact on absenteeism, satisfaction with quality of work, and so on. So what are we expecting as the impacts? Improved health and well-being in the EU healthcare population, and we know this is more important now than ever. Positive impact on the work conditions that staff work in, and then improving policies on health and well-being at governmental level. Dissemination of the work is vitally important, and influence on policy dialogues and policy briefs. And a number of countries have started those conversations with various bodies within it. To acknowledge the European Union funding, and then our website is there, Magnet4Europe.eu, and then our Twitter account at Magnet4Europe as well, which is a very dynamic Twitter account, and a lot of hospitals around Europe have set up their own Magnet4Europe Twitter accounts as well, and there's a lot of collaboration and information through those. So thank you very much.
Thank you very much, Professor Jonathan, for sticking to the time also, and for this very, very nice presentation, very informative presentation. So maybe we have time for a question.
Yes, Julia Flintrop was asking that it was a very interesting project. Could you elaborate on challenges you came across in hospitals because of, on the one hand, limited resources, and how the general health system is organized, and in how far structural employee involvement played a role in the project, and also in contrast to the US?
Yeah, Julia, that's a really good question. There have been challenges implementing it because I think I'm in. Yes, sorry. Can you hear me there?
Yes, we can hear you, Jonathan. Can you hear us? Can you hear us?
Sorry, I lost you there again for a second. Apologies for that. Yes, so yes, there have been challenges in implementing it. The hospitals have to use their own resources in relation to the implementation of the Magnet. That's part of it. But what hospitals have done is that they have identified key champions in each of the hospitals to develop it. The resources between some of the European hospitals and the US hospitals are very, very different. The funding system, the US system, is predominantly privately funded. The vast majority of our hospitals are coming in relation to from the public purse, from state funding. So there are very differences in there in relation to it. But what they're finding is there's a lot more in common between the European and the US system in relation to patient need, in relation to the organization of nursing and physician work. So there are differences within the system. There are differences in funding. There are differences in resource available. The other thing is, as well, is that many of the US hospitals have had this Magnet process in place for a long time. So they have a lot of resources there in relation to it. But what we're doing is we're looking at how modifiable it is within the European system and what we can do there. And that is we're both learning through that. but there are differences. There are resources that are an issue, and particularly during the COVID-19 pandemic, where staff had to be reallocated, staff had to be reallocated back into clinical areas who might have been in a leadership management role. But overall, we're finding that it's working very, very well, despite the challenges. I think hospitals see the need for this, particularly at this point in time.
I think, Beatriz, we might have time for another question before the break. Daniela Weber was asking, thank you for this very interesting presentation. If I understood it right, the communication of leaders in the hospital is very important. And do you see differences between the communication of leaders in the US compared to Europe?
No, Daniela, we see a lot more similarities than differences. To be honest, we can see that the structures are very much the same. What has struck us is, Daniela, is the strength of the relationships between the European and their US twin. They really developed strong relationships. They find at the beginning, I think, to be honest, the European hospitals felt that there were a lot of challenges and the expectations were very high. But this has changed over time, and there's become more of a meeting between the two in relation to it. And I would certainly see that there's a lot more in common between the leadership between the US and Europe than differences. Yes, they do have some different structures. Even within Europe, we have different structures. We can see that, but there's a lot more similarities than differences.
Thank you.
Thank you.